Ravi, along with some of our other CPS team members. And today we're hoping that somebody's brought a case that we can discuss and sort of mull over. I'm very happy today to be joined by Anne-Marie, a longtime CPS collaborator and has been on CPS for quite some time. And you can listen to her on the podcast and always has a lot of or a ton of teaching that she contributes to CPS. So I'm really happy to be co-discussing any potential case that you have today with her. But before we get underway, I know we'll give Anne-Marie some time to eat her lunch, and I'll ask maybe some of our team members to unmute and introduce themselves, and then Anne-Marie after that. I'll start with Yasmin. Yasmin, how are things going?
Hello, everyone. I'm doing very well, thank you. Preparing for my step 2, which reminds me, if Sarah is watching this, I hope she's doing well because I have been thinking about her, our friend Sarah told, and everybody that's preparing for the step 2, you can do this.
Absolutely. A lot of questions and a lot of I would say summary points. So using your slide decks and using your first aid. I used to use first aid for the boards back in my day. And then Hui, how have you been?
Hi, yes, I've been great. I'm actually working hard because I'm doing a review article now, and it's so difficult. There's so much information, but it's nice. I'm learning a lot as well.
You have a great point there. What's interesting is every year medicine is continuing to evolve and expand. So whatever you learn now may not be relevant next year. And there may be actually each topic may develop 2 more concepts that you have to learn. So anybody taking the board exam now has a harder time because there's much more material to cover. And if you look at the books, the evolution of the books, they've grown bigger and bigger and bigger as more concepts are found or discovered. Deborah, how you been? You having some tea, I see.
Yeah, actually now it's coffee. I'm good. I was traveling on the Easter. It was really good to take some time and a break. And yeah, I'm happy to be back. On Saturday, we'll have the episodes that Yusuf is doing. That will be the management reason that is being really good. I want to invite it to everyone. And I think that's it.
Oh, yes. Saturday will be management reasoning. And then I also want to make a plug. Thursday, I wasn't able to do last Thursday, but we'll do a rapid response VMR. And I'm kind of hoping I'll have a surprise for you. The location will change from my office to somewhere else. So we'll see what I can do. Yep. And Noah, how have you been?
I've been good. I'm preparing to take my OET this week so I can do the ECFMG certification in time. So yeah, practicing my speaking, my writing, and so on. It's pretty chill.
You'll have no problem with that. I can vouch for your speaking. So you presented some great cases over the past few weeks. So I can attest to your significant or your control of the English language. So you won't even have to worry about that. And let's see who else. Ibrahim is here. And if you're able to unmute and just say hello while we, again, making a plug for a case if anybody has anything.
Yeah, hello everyone. It's so nice being here again. Today we had heavy rain where I live, which is something unheard of in the middle of the desert. So school got canceled, which I think was a pro. But yeah.
Oh, wow. Is it usually rain that heavily?
No, it's usually that we have like 2 to 3 days during the entire year where we have this much rain. And then it's very usual for school to get canceled because like the sewage system cannot handle all of the rain at once. So, yeah.
Yeah, sort of. I think Anne-Marie they could also mention that when we get snow over here, that's when school gets canceled. So yeah. So yeah, but actually the season this year hasn't been too bad, or last year we haven't had any snow at all. So, oh, Deborah, you have a case finally.
Yeah, I'm doing a translation now from Spanish, and if as no one has, I think I can present.
Yeah, that'll be wonderful. We actually have the whole hour, so take your time. So, and before we get underway, I want to ask Anne-Marie if she's ready to introduce herself as well.
Yes, I have finished eating lunch, so sorry about that. Hey everyone, I'm Anne-Marie. I'm a hospitalist. Excited to discuss today, but I also do have a simple case if you want that too, just depending on how long the translation takes.
I think Deborah should be okay, because I think it would be great to co-discuss with you. So are we good, Deborah, or you feel like
Yeah, no,
it's up to you?
No, let's go.
All right,
Yasmin,
let's rock.
Yasmin can help me if I say something in Spanish. Okay, the chief complaint was muscle weakness. I will stop here.
Interesting. I'm sort of going to start early with this, but muscle weakness, I'm going to think maybe primarily something in the muscle, or maybe something that may be incorporating the nervous system. That's pretty much, it's early, I'm just going to leave it there, but I'm going to ask Anne-Marie if she has anything more to expand on.
Yeah, I think in this case, knowing the age is going to be really helpful information and the past medical history, because that's going to help guide the differential. But I like to remind myself of what's needed for muscle contraction. So thinking about, a signal from the brain coming down through the nerve, going through the neuromuscular junction. And so you're going to need the use of the neurotransmitters to the nerve itself. And so then the electrolytes are going to be really important for generating the action potential, such as potassium, such as calcium, such as magnesium, to get the contraction. And then also think of the importance of some of the hormones as well in this process. So thinking about just to kind of center on it. And then I'm just going to want to know, is it unilateral or is it bilateral? Is it proximal or distal? Because all these things are going to help inform the differential, and then also know about the time course, because that's also going to be really important. Is this something congenital, or is this something that's been slowly progressive, or is this something that's been really quickly ramping up? So excited to hear more information.
Back to you, Deborah.
Okay, so it is a 27-year-old female. She came to the ER presenting a facial edema that extends to the neck, is associated with plaques that are erythematous in the shoulder, back, and extremities. She tried to pass like some top treatment, but didn't resolve, and has been with muscle debility. She denied any past medical history, any medication, any family history, any allergies, no alcohol, no drugs. And I can stop here.
You want me to go first, Anne-Marie?
Yeah, that'd be great.
So actually, we have a couple of complaints here. What we can do, we can divvy it up. But what really stood out to me, there is now, you have muscle, and Anne-Marie did a great breakdown of how we should approach muscle weakness and what we would anticipate from further history and aliquots. But then now we have involvement of the skin, and then facial edema could border on skin issues, but we could also think about facial edema due to the different layers of the skin, including muscle, the skin itself, including the epidermis, dermis, and subcutaneous layers, and then also the vascular system, which could also lend to development of edema. And this erythematous plaques on the shoulders, maybe I'll leave that for Anne-Marie, but what really stood out, system one thinking, what really jumped out was causes, and using that sort of scaffolding that I kind of came up with on the spot to think about facial edema. We started thinking about could there be a primary issue with the skin itself? So could there be something like angioedema is probably a very common cause I've seen of facial edema. And then you go into systems, maybe starting with maybe an infectious etiology. And actually last Wednesday, CPS VMR, we had a patient with facial edema, and then also there was edema of the body, so anasarca. So is the facial edema a systemic issue, or is it localized just to the face? If we're going with the face, then I have to worry about infections of various layers or components of the mouth. So some things like dental abscess, tonsillitis or tonsillar abscess, retropharyngeal abscess, sinusitis, lymphadenitis, Ludwig's angina, Lemierre syndrome. So some areas which could be swollen due to infection. Then autoimmune phenomena. We've had adult onset Still's disease. We've had, like last week, a case of dermatomyositis, where you can also develop some facial edema. And then going back to hypersensitivity reactions, we have angioedema. We then also can have DRESS syndrome, which is kind of interesting here. DRESS syndrome, you can have systemic skin involvement. You also can have a swollen sort of feature of the face as well. And other things that I can think of, endocrinological causes, especially with this muscle weakness, hypothyroidism can come to mind. Myxedema coma has a unique feature where you get facial edema, but I would look for other associated features like hypothermia, bradycardia, and so on. But you do get muscle weakness. And then the adrenal conditions can also portend to edematous states. So Cushing's disease, notably. So you get other associated features that can have a metabolic signature. You can get a buffalo hump and so on, and skin fragility and so on. So there are a couple of things in this sort of a framework for explaining this facial edema. But I'm going to ask AMK if she can take some of this and maybe relate it to the plaques on the skin, on the shoulders, and then also with this muscle weakness. And I also want to note the patient is young, so at this age, any one of these endocrinological phenomena can come into fruition. Back to you, Anne-Marie.
Yeah, that was such a good explanation. And I think we have a whole lot of different hypotheses that more information on the distribution of the muscle weakness, time course, other associated symptoms will help narrow down, and if the edema is localized versus more diffuse, as was discussed. I think definitely when I hear skin manifestations plus muscle weakness, kind of my type 1 quick thinking like immediately jumps to dermatomyositis, thinking about the Shaw sign. But I think that we have to take a step back here and say, are these two related, or are they separate entities? And a 27-year-old without past medical history, I think there's overwhelmingly like they're related, but there's still that small chance that they aren't. And so I'm going to be thinking about my overlapping Venn diagrams and try to be coming up with a differential for a rash, differential for muscle weakness, differential for edema, and see where the three coalesce. And that's also a good opportunity to maybe remember something that you might forget if you just, focus on just one of the things. So, here, when thinking about a rash, I think a picture is worth 1,000 words, and getting, some more exam history and everything, because it does mention plaques. So what these plaques look like, the time course. I'm going to ask about sensitivity to the sun, because another thing that I would think about in a young female is lupus. And so thinking about that, as well as like exposures to toxins, to new things like insect bites, everything like that. And then, I agree with kind of the discussion before about the facial edema. So I'm definitely going to be curious about the distribution. Is there involvement of the eyelids? Does it look like nephrotic syndrome with anasarca everywhere, or like liver disease, or are we worried about some sort of obstructive process in the neck, like a thynoma, or like I wouldn't expect it in someone so young, but like SPC syndrome, something like that. So I'm really excited to get some more information to help us along in this case.
Back to you, Deborah.
Great discussion. Going for the exam, her vitals were everything normal. She was not in acute distress, was resting comfortably. Cardiovascular was regular rate, Rateman, no murmur, rubs or gallops. The lungs were clear to auscultation bilaterally. Breathing on room air, the abdomen soft, non-tender, non-distended. And then in the extremities, she feel like a debility in the proximal of superior and inferior extremities, pain on the shoulder and the pelvis, more in the pelvis, and had like lesions, erythematous crabs and periorbital, nasal, perivocal, in the thorax and in the back. And she had the Gottram sign. Besides that, nothing else. And then we did the labs, and the labs, everything was basically normal. And she had for AST 227 and ALT 114 and CPK 2136.
Would you repeat the skin exam part? I think I missed some of that.
Sorry, I will. Okay, so she presented like some lesions. There was erythematosus, crabs, I think I'm saying right, in the periorbital, in the nasal, peribuccal, in the thorax, and in the back. And she got some Gottram sign.
Emery, you want to go first with this one?
Yeah, certainly. So here, the vitals are fairly normal, which isn't necessarily surprising because the center of gravity seems to be, the weakness, and not like some other process, but that does kind of help us with the differential. Here, I think the lung exam is interesting because if we are thinking about muscle weakness, one thing I'm always thinking about is, could there be an interstitial lung disease associated? Sometimes you can see something called antisynthetase syndrome. So certainly the physical exam isn't perfect, but I definitely be keeping an eye out for crackles, tachypnea, things like that, and also be thinking about like there be with this muscle weakness some sort of diaphragmatic involvement as well, which it doesn't seem to be the case here. The pain in the shoulders is interesting because that does kind of make me pause and think, a lot of times you can get pain with things like dermatomyositis, the polymyositis, but it doesn't tend to be as prominent of a sign. So I'm thinking, is there some involvement of something like PMR or something like that? But the age demographic makes that much less likely, as usually this occurs in patients over the age of 50. And so, it certainly could be a part of an inflammatory process or the muscle, but I'm just kind of taking a step back and trying to think about, why there might be pain in the shoulders and the pelvis. Is there, some involvement of the bone itself or an arthritis at the site? Is it pain worsened with range of motion, or is it predominantly in the muscles? And then the proximal involvement doesn't surprise me. Most inflammatory muscle diseases are proximal involvement. You can get some distal involvement if it's like a length-dependent polyneuropathy, or with something like, oh, I just went blank on the name. It can be sometimes, Ravi, can you help me out? Like the more slower process, it can sometimes be asymmetric, starts with an A. I just went blank on the name. Well, I'll come back to that and put that in the chat. But it definitely, the proximal involvement does make me think more about an inflammatory muscle disease. And then we also have this skin involvement. And so we have Gontran's sign, which can be a sign of dermatomyositis, and some people even say it's pathognomonic. And these are small purple and red flat papules on the extensive surfaces, particularly of the elbows and hands. And so that definitely is making me think that an inflammatory dermatomyositis is more likely. And then, you know, the periorbital involvement, you can also get the heliotrope sign. And so I think these findings could certainly be consistent with dermatomyositis, but I'm also still keeping in mind things like lupus, kind of other things that can have pretty diffuse skin involvement as well. Ravi, anything to add on the physical exam? And then I'll let you discuss the labs.
Not much there. You did a great walkthrough of, I guess, inflammatory causes of something like this. And I absolutely love that you had described the Gottron's sign in conjunction with the papule. So you can actually either have the raised markings on the knuckles versus the flat appearing Gottron's sign, and then moving through the heliotrope rash. And this all does kind of pivot towards this patient likely having dermatomyositis, but I got to be overly cautious because I don't know if you know, the last 2 weeks we've had actually great rheumatological cases. Noah had presented, and then Mario had also presented, and last week we actually had a case where it was I think we had talked about proximal muscle weakness, and the anti-synthetase syndrome was the case that you had nicely described there. And I think the hand findings really did pivot towards anti-synthetase syndrome. You're absolutely right about ILD being part and parcel of this process, but we don't know at which stage we're catching this patient. Maybe later they'll morph into having some interstitial lung disease, but that is one component to think about. One other thing is, which I didn't express last week, but now I've learned to think about, is maybe if dermatomyositis, maybe this is just on the surface, what could be in the background. This could be due to a paraneoplastic syndrome, namely malignancies. So malignancies that we have to worry about, namely ovarian carcinomas, lung malignancies, pancreas, stomach, colon cancers, and maybe lymphomas. So I'm not getting any flavor of these in process with this patient, but it's just something to think about. There's no weight loss. I mean, although the patient has overt inflammation, I wouldn't be surprised if there was weight loss as well in a young person. But that will be something to think about. Is this a primary process, or is this a secondary due to a paraneoplastic syndrome? And everything is screaming to me dermatomyositis. One thing we also have to worry about, although the patient hasn't been started on this, but steroids is medications that we would use in this case, and that can definitely have its own side effects and cause a proximal muscle weakness as well, but not to the degree of having skin involvement and so on. Although it can cause thinning of the skin and purpures, development of purpures as well. But in this case, I'm right on board with what Anne-Marie has mentioned, and kind of intrigued to see if this case develops, if it goes off on another tangent, and maybe there's something else that's bubbling under the surface. Anything else, Anne-Marie?
No, I think that was all. I think one thing I didn't mention with the vital signs, if they were abnormal, that might make me think more about an endocrinologic sign if they were really tachycardic or really bradycardic or, something like that. But the fact that they're normal and we don't see any other signs of hyper or hypothyroidism makes me think it's less likely. I don't see the deep tendon reflexes recorded here, but those are usually normal in dermatomyositis. Occasionally, if there's a necrotizing myopathy, if you get such profound weakness, you can actually lose the deep tendon reflexes as well. But if those were absent, those would point more towards a neuromuscular cause most of the time.
Absolutely, yeah. And then the labs, I forgot to sort of comb through the labs, but what does stand out here, the CPK is elevated. It's not devastatingly high, so I don't think we have a massive muscle necrosis going on, but sort of a mild intensity, moderate inflammation of the muscles. And I think this is to be expected with dermatomyositis. Again, we're catching the patient on a certain trajectory, and maybe it's early in the process, or maybe the patient had a much higher CPK at one point. AST, I think, pretty much is explained by the rhabdomyolysis. So AST is greater than ALT. I don't think at this point we have liver involvement, but you also have to sort of be cautious as well if there's any abnormal labs developing with alkaline phosphatase or bilirubin or any coagulopathy or hypoalbuminemia, that there may be involvement, acute or chronic, of the liver. But at this point, I wouldn't forage into doing any significant liver workup at this point due to the rhabdomyolysis. But I'm wondering if there's any more elaboration on this case by Deborah, but I'll pass the mic back to Deborah.
Great.
Ravi, can I just say something really quickly?
Oh, absolutely. Yes, please.
Yeah. So one thing to remember is while ALT is more specific for the liver, and I like to remember that is L for liver and then L for long because it also has a longer half-life, but it's still expressed in muscle cells with the AST to ALT ratio in about like a 4-to-1 pattern. But if you get enough muscle breakdown, you will get some leakage of ALT. And usually you get that 4-to-1 AST to ALT ratio in the beginning, but as time goes on, since ALT has a shorter half-life, you can see kind of equalization of the two. And so that's just something I like to remember is kind of if something has been going on a long time, just because the ALT and AST are equal doesn't mean that it can't be from the muscle.
And if people want more information about breakdown of liver enzymes, Anne-Marie has a great schema from way back. I remember that you had made for dissecting the liver enzymes. So do take a look at that. Back to you, Deborah.
Great discussion. So the patient started to feeling like dysphagia, changes in the voice and dyspnea, and then was done a spirometry on her. And the vital capacity, the peak flow, the mouth pressure, they were low for the expectation for her age. Then she received like pulse of corticoid, and in a few days she started to be able to eat from her mouth again because she was not being able, and she started feeling better. And then we have to talk with the rheumatologic rheumatologic specialist to get the diagnosis, and I will review in the next aliquot.
Interesting. Anne-Marie, you brought up about the lung disorder. Do you want to maybe elaborate at this point what you were thinking?
So I think that any time where you have an inflammatory myopathy, they oftentimes can have lung involvement as well in the form of ILD. And as Ravi made the point, this can manifest at different times in the disease, and sometimes the manifestations can be initially very subtle and then later can be progressive. And so usually when you diagnose an inflammatory dermatomyositis or like a myositis, usually you'll get a CT scan to look for involvement of ILD. Certain types of inflammatory myositis have higher risks of being associated with ILD, and certain antibodies are more associated, such as, you know, the anti-synthetase syndrome has a high risk, and then some others. But oftentimes, once you get to the nuances, I let the rheumatologist really weigh in on that. But if you do diagnose someone, even if they aren't having symptoms, a lot of times it's helpful to get a 6-minute walk, see if they desaturate, get initial screening to look for it, because it can be subtle. And if it's present, you want to catch it at the beginning. So I tend to think that these are still associated process. The weakness with swallowing is a little bit interesting to me. I don't know if Ravi has thoughts about it. I don't generally, you can get some weakness in the esophagus. I like to, you know, think about like which part of it like would be involved in everything. I don't think of it as often with dermatomyositis. It can sometimes occur and then sometimes occur in the necrotizing myopathy, but I think with all the other signs of it, it would still be something I'd consider. Ravi, what are your thoughts on that?
You actually nailed it right there. So the muscle, if you think about like last week, I think it was Mario presented that patient had trouble swallowing. And if you remember from anatomy, that the upper 2/3 muscles of the esophagus are skeletal. So if we have muscle involvement, why not the skeletal muscle of the esophagus? So that could explain the difficulty with swallowing. But what's interesting is I did also elaborate last week. It's very interesting that this case is helping to reinforce learning from last week. So with another inflammatory myopathy, which is not the case here, but inclusion body myositis, you can have an involvement of the cricopharyngeal muscles. And so in a case like that, you'll have a patient maybe with more, maybe in the first aliquot, difficulty with swallowing. But in this case, I think it's just involvement of the skeletal muscles of the esophagus. As the patient does have proximal muscle weakness, why not the rhabdo? It could also be affecting the esophagus. The other thing I think you had kind of mentioned, overlap syndrome. So we have to also be careful. I don't remember an anti-synthetase syndrome. I mean, the case last week, it was also the hands. So here the hands going back to the gotron. Like you said, pretty much these skin findings can be pathognomonic and can shift to this diagnosis rapidly. Yeah.
I think of the mechanic's hands, like the cracked, fissured hands, especially with the anti-synthetase syndrome, but I am by no means an expert on it.
Absolutely, yeah. That in that case last week, that really did hit home with the diagnosis. But here, I think dermatomyositis is in the running, and I think it can pretty much explain. But then I have to be cautious. I've learned to be cautious because the last few weeks, the cases, there've been a rash. There was a rash which resolved on the palms and soles and had absolutely nothing to do with the diagnosis. So you can have two simultaneous issues going on at the same time. But here, I think this is pretty much indicating that, or all can be explained by dermatomyositis. And you also mentioned about the other rashes, Holster sign, the V sign in the front, which can be photosensitive, and then the Scholl sign. So the Scholl sign, like you mentioned, could explain the rash on the shoulders. Back to you, Deborah.
Great discussion. So the antibodies, she had anti-RO that was positive and anti-JO that was negative, and has done an electromyogram that presented moderate to severe inflammatory myopathic compromise. And then she was diagnosed with dermatomyositis. I remember of Ravi this case when I saw yesterday, because we have been going from rheumatological cases, and I was reading like about the esophageal, the dysphagia is the most commonly that is reported in the gastrointestinal symptom. And what Emery said about the interstitial lung disease, it's associated with anti-synthetase antibody, and then can be associated with the anti JO1 too, and like 30 to 40% of the patients with the dermatomyositis can present with interstitial lung disease. So yeah, great discussion, everyone. Was just to continue with our rheumatological cases.
Absolutely wonderful case. Yeah, Emery, we've had a number of rheumatological cases over this past few weeks, which I've been very happy. I've been able to brush up on my rheumatology. It really does make you think, though, if you look at the hypothesis generation with just the complaint of proximal muscle weakness or muscle weakness, it's quite vast. But I really appreciate you being able to translate this case from Spanish and being able to present it so well, Deborah. I appreciate it. Thank you. Anne-Marie, any reflections?
Yeah. Yeah, thanks so much for presenting. It's always fun to discuss, and I think you can always learn something new. I think for me, it was just like knowing that dysphagia could occur, but not really associating it with it as much, and just being reminded that it is one of the most common GI manifestations of dermatomyositis was kind of a great reminder and learning point. So it's always great to discuss and learn from everyone.
All right, great. And I think we have Noah. Or is it Yasmin? You doing the teaching points? Oh, hey. Thanks, Yasmin. Take us home.
Yeah, thank you for this amazing case and amazing discussion as always, Dr. Ravi and Dr. Emery. And for the teaching points, our first approach to weakness, we should locate the weakness if it could be muscle versus nerve, bilateral versus unilateral, proximal versus distal, and as well as the time course. Now, what is the issue? Dr. Emery gave us like this muscle contraction chain. Remember that the brain sends a signal, the nerve, then to a neuromuscular junction, neurotransmitters, and electrolytes that are needed for the depolarization or repolarization, as well as hormones. So we can think, well, an issue could be in any of these parts of this chain. Now, for approach to edema, facial edema, we have to think of the skin layers, vasculature. Could this be a primary issue of the skin? Also, we should consider localized versus systemic. For example, angioedema versus anosarca. Remember that edema in endocrine disorders are accompanied by other signs and symptoms such as skin fragility, buffalo hump, etc. The plaques in this patient, another thing that we have to ask is, could this be caused by photosensitivity? Is there eye involvement? Where is it located? Because there are some autoimmune diseases such as dermatomyositis and lupus in young patients, especially women, that have very specific signs. Now, for pain in shoulders and pelvic girdle in young patients, we have to determine, again, could this be muscular? Could this be nervous? Is this inflammatory pain? For inflammatory pain, remember the morning stiffness and the pain that is worse in also in the morning, and as well swelling, presence of swelling. A very good point that Dr. Emery made is the antisynthesis syndrome. In a patient that has muscle weakness and myositis, also search for lung crackles and diaphragmatic involvement, because pulmonary fibrosis is very frequent in patients who have antisynthesis syndrome. And there is this Venn diagram. Also, the Gottron sign that we should remember is pathognomonic for dermatomyositis. And the etiology of dermatomyositis that was Dr. Ravi was talking about, it could be idiopathic versus paraneoplastic. It could be an antibody-mediated vasculopathy. It could be associated with malignancies such as ovary cancer, lymphoma, lung cancer, stomach cancer. So be very wary when a patient comes with you and has these signs to also ask for these kinds of issues. ALT is more specific for the liver, but it's still expressed in muscle. So if you get a high muscle breakdown, you can get a high ALT-AST ratio. And inflammatory myositis can have lung involvement, which starts again with several manifestations, although may evolve to fibrosis. So we should start with initial screening, such as a CT scan, to look for signs of ILD, and a through PE is important, such as assessing the patient's walking, if they get tired, if they cannot breathe, etc. And the last one, esophageal involvement, is the most common manifestation in dermatomyositis, because we have to remember that the upper 2/3 of the esophagus are a skeletal muscle. So there can be dysphagia due to antibodies against this muscle, as well as the cricopharyngeal. So these are all the teaching points for today. Again, thank you. And back to you, Dr. Ravi.
Thank you, Yasmin. That was absolutely fire. So I really appreciate you doing teaching points, Noah for doing scribing, and Deborah for a fantastic case there. Really enjoyed that. Lots of learning there. And to Anne-Marie, who's our VMR legend, for joining today on our off day, and also volunteering just before we started VMR to co-discuss. So I really enjoyed co-discussing with you. Any final words, Emery?
Oh, it was a blast. So so glad that I got to join today.
Oh, great. Always come back and visit us whenever you're off. All right, everybody. Tomorrow we have Jack and Charmaine in the afternoon, so please join us for that. Otherwise, have a great rest of the Tuesday. Take care. Bye.